So really today we're going to turn it over to Premier. They have a really nice agenda set. Not all of our sessions have had even kind of an idea. It was like, let's see what we're going to talk about today. So this is really going to be nice because you're going to get a lot of information about what is an ACO. We get a lot of questions about that. They hear it maybe in a concept in a class, but how it relates to the real world and having actual real people on the call talking about what they do, I think is going to be super helpful. And then as you all can see on the slide, it shows kind of the different folks who are with Premier. And so they'll be sharing some of their experiences as well. So I'll keep an eye on the chat for questions that come up. I'll only try to interrupt, not too much, and only if questions maybe relate to what you all are talking about. But thank you all so much for being here. And I'll just turn it over to Annie, who will kick us off. Thank you so much.
Thank you. So I can go ahead and share my screen and pull up our slides. So you guys can let me know when you see everything. Let's see, slideshow. Okay.
Perfect. Looks great. Thank you.
Okay, so we are presenting an intro to ACOs, and I know that several of you have turned in questions to Quincy, and a lot of those questions will be addressed in this presentation, but of course at the end, feel free to ask any additional questions that we haven't answered. So this is just who we are, and then each of us will be presenting our parts. Michelle is our Chief Operating Officer. She'll be giving an overview of just what is an ACO, what is value-based care, where does Premier fit into that? And then Greg is our VP of Operations. He will be discussing more about our company, about Premier, and what we do to help. And then Kathy is our Director of Clinical Programs. And those of you who are interested in internship opportunities, you want to listen to what Kathy has to say because a lot of the internships are in her department. So she really does a deep dive into the clinical programs and ways that we actually improve quality and reduce those costs. And then Mariana she graduated from the UT healthcare program a few years ago. So she has been in your shoes. She's our project manager for the strategic programs department. And she just has a lot to say about, she's so knowledgeable about value-based care, and she's going to talk about what different careers are available out there in value-based care and in ACOs, just to give you an idea of just some things you might not have thought of before. And then my name's Annie. I also, I recently graduated from the Master's in Healthcare Leadership and Management at UTD. So I'm familiar with a lot of those classes and the program you're in right now. I came in as an intern coordinator, so I help organize the intern program, and I'm also now the strategic programs analyst. And I will be, here's the agenda, I'll be talking about our upcoming internship opportunities. And now I'm going to hand it off to Michelle. And Michelle, I guess I know one of the questions was that the students wanted to hear a little bit about our background, and how we came into this field. So if you want to just first give a little brief intro to who you are and where you come from and all of that, and then Michelle will share with us more about ACOs.
Absolutely. Nice to see, well, some of you today, and sorry I can't be on screen. I'm just a little, feeling a little sick, but looking like I feel a lot sick. So I'm going to stay off camera, bear with me. But I want to introduce myself and the company just to kick off the discussion today. So like she said, I'm Michelle Storto, COO. I've been in healthcare almost 20 years. So the majority of my career since I've been out of undergrad, I've been working in the system. I actually started working in a dental practice, and I just needed a job outside of school. And I thought, well, gosh, this is interesting. I've never seen a dynamic where the customer doesn't pay the bill. And it was really a curiosity that was born in me. And so I went back to school and got my MPH with a concentration in healthcare administration. And during that program, learned a lot about the system. Really, I had been interested in my bachelor's in political science, and I came to understand what I had been interested in all along was health policy and what's happening to the system. And this is one of the more important social problems we need to solve. And so working in the system and seeing the opportunity got me hungry for it, and I had the opportunity to grow pretty quickly, got hired into a health plan Right after I finished my master's, I started working for one of the better known value-based care health plans, CareMore Health Plan, which is now owned by Anthem. So I was fortunate that early in my career, I just expected to look at solutions that had value and were centered around outcomes. So for about 11 years, I've been working in value-based care, and it's a really exciting, important job. So I'm glad you're here today and you're interested. I want to talk about value-based care as a system and introduce you to Premier. If you can go to the next slide, Annie, I'll first talk about value-based care because it is a really big job. There are no days when you can turn off your brain and just roll in and punch the clock, because we are essentially full-time problem solvers. So what we're doing is we're trying to fix a system that has gaps and issues that are growing. So what's happening in our system right now is that patients are getting sicker. The average adult in the US, about 60% of them have some form of chronic disease that we're treating. Actually, in Texas, the average is 2 per patient. So that's what we're dealing with in our practices, is that we've got multiple medications, we've got complexities to address. At the same time, there are pricing compressions. So we're paying providers less in many cases to treat sicker patients. What's happening is that also we have a decline in fertility, right? Fewer adults are working. And as you know, the baby boomers are aging into the Medicare system. So we have essentially a growth in the number of Medicare aged adults who need to be covered and fewer people to pay out of their checks. So Medicare spending is actually supposed to outpace the GDP. In the next decade, it's going to double to $1.3 trillion. And this is stuff we talk about with our new employees when we onboard them. It sounds probably like some things you hear in your classes, because these are the systemic issues that we're trying to address in the work that we do. So what we're trying to do is decrease that waste. Some of the solutions you see when you consume healthcare is, costs are going up for you and you're cost sharing. Does that solve a problem for a healthcare provider like us? No, people want to be seen less when their copays go up. It's harder to access patients. We have rural patients. We have social determinants of health impacting health. So health is a very dynamic concept. And as people get sicker and there are more of them to take care of, and providers are being paid less, and then we're having fewer patient visits, we have to somehow help people get out of this cycle and break it. So all payers, private, federal, state, are motivated to use value-based care solutions, basically to reduce that waste, whether that's to decrease our national spend on the public programs or to make more profit. It's become more difficult to make profit as a health plan versus when they used to just print money. Really, the waste in the system is often attributed to 2 things. One is that our system is fractured and uncoordinated, largely attributed to an EMR system that grew up in the private sector, right? Multiple systems that don't talk to each other and have no financial incentive to help us do our jobs better. The second is that the system is fee for service, which is a compensation model that incents abuse. See more, do more, charge more. If I am an orthopedic surgeon and I've got to make a very discretionary clinical call on cutting off your leg or treating it with an infection, what do you think the compensation difference is in an amputation or giving you an antibiotic and charging for a visit? It's huge. And so when I'm right on the fence, no matter how ethical I am, if I'm within my rights to make the call, and if I just have become disillusioned by diabetic patients and I don't think you're going to do what I ask you to do and I'm going to cut off that leg anyway, I'm going to cut it today because I'm a surgeon and I cut. So this is what happens in the system every day, and we're looking for ways to keep people from that engine, essentially, that fee-for-service engine. So the ways that we do that is we incent providers, we change that mentality, and we try to fix the fractured system. Those are the main 2 things that we're doing. So providers can increase their skin in the game by taking on more ownership of outcomes and being paid in value over volume through models like capitation, rewards incentives for specific quality or utilization improvements. And then the really big one, and what we really do every day here, is upside and downside shared savings. That's essentially the margin between what a patient's supposed to cost and what they actually cost. So when you create savings, you can enjoy in that profit with a payer in a contractual arrangement. Now, with that comes downside risk. If the patients cost money, that's what I mean by skin in the game, usually you have to pay back some of that money. This is really important because what payers are doing is affording improved benefits. See that cost sharing going up problem? How do I keep my cost sharing from going up if I'm a payer? I guarantee my profits. I guarantee I can afford them by making the providers pay me back when we don't make our goals. So that's what our group does, is we help providers get involved in complex arrangements like that increase their skin in the game, their opportunity for earnings, and their opportunity to make an impact. And let's face it, if you're a health plan, your opportunity to make an impact on a diabetic patient's outcomes is not as strong as their primary care physician. So this is why these models are emerging. And I tell you what, they are not going away. Lastly, on this slide, I just want to say that a lot of these models are enticing, but independent providers particularly are not equipped. They don't have the infrastructure to take on managing something like this. They need help. If you've gone to your primary care practice, and unless they're a huge health system, if it's a onesie, twosie doc, if you see how hard it is for them to get you in on time and to get you the bill you requested in the mail and all the things, just how hard it is for them to function in their business, imagine them trying to operate complex, programs like care coordination, and also how can they do that without any scale, right? They're pretty small. So that's what we do, is we help these providers not only enter into arrangements like this, but also handle the pressures that are on them, the negative pressures, the fee reductions, by increasing their earnings. Most of this is pointed at the primary care because of their influence on total costs. But primary care providers only get 6 to 7% of the total spend. Usually over 40% of a spend, whether it's commercial or Medicare, goes to hospitals. So you have these providers in these, many of them small businesses, with a lot of influence over a lot of costs, but not a lot of resources to do much about it. And they're incented to try to help because they're getting a tiny piece. Getting them a little bit more really helps their businesses. So that's essentially the arrangement that we have with them. And on the next slide, I'm going to show you literally what that looks like, because I don't know about you, but I'm an operator, and the first question I have is, well, how does that work? So how this looks is the health payers, this general term for any health plan, right? Whether it's the government, CMS is the payer in some case, they're paying the claims, or if it's Blue Cross or Humana or any of these other health plans that offer private health plans. The majority of our membership are on Medicare programs, whether they're private or they're straight Medicare recipients. We are an entity that works between the provider and the payer. We loosely refer to ourselves as an IPA, an Independent Physician Association. But typically, IPAs are physician-owned. You see a lot of these on the coast where you have these very heavily managed care environments like Florida and California. And there are these huge provider groups, and they say, we don't want to pay a health plan to do this. We want to do it ourselves. So we are one of the closest things to an IPA you get in Dallas-Fort Worth, which is not as far in that direction. And we're working with these small practices, but they don't own us. We are a private company. We are much more like a managed service organization, which is referred to loosely. Healthcare loves the acronyms, so you got to write all these down. And it's referred to as MSO. But typically when we in the industry talk about an MSO, we mean a vendor, somebody who you can hire to outsource your claims processes, to outsource your various functions that a payer might provide. We do not do those things, but we do the administrative, the management, the contracting components, and the performance management. And then we share in an opportunity to earn rewards with the providers. So 100% of our income is value-based care, meaning if we don't create results, we don't get paid. So that is why we are so motivated to create results. And that's one of the reasons we're so high performing. So in these contracts, typically you'll migrate along a risk continuum from early rewards into higher downside risk, like I was talking about. Those providers do not want to take that downside risk. So we take that for them. The provider is still seeing the patient, and we're probably providing some services behind the scenes to help them do that better than they've ever done. Kathy's going to talk a lot about that. How do they get information faster? How do they focus on which patients need to be seen when? How can they be action oriented? The system as it exists today, one of the main problems is it's incredibly passive. In order to seek care and help, a patient has to pick up the phone and call their doctor, and they have to want help in the first place. So one of the main things we do is make it more proactive and connect the provider when they should see the patient, not when the patient asks to. Typically, when the patient asks, it is too late. So we are looking for, we're doing patient stratification, we're using data to identify opportunities for intervention, and then we're recommending those interventions, in some cases even acting on it, like care coordination does. That way patients don't end up in the hospital when they could have been seen all along. I like to say, and you can't repeat this because it is not an industry-wide description, but I like to say we're a dating service for patients and providers, like Bumble. We're getting them together the way they always wanted to be, always should have been, but for some reason they couldn't get there. So we help them connect, and we help them identify who are those patients who are the right ones to connect with. Lastly, for my section, before I hand it over to Greg, is the real question you have today is, okay, well, what in the world is an ACO? So Premier is this sort of IPA, sort of MSO. We're an intermediary between the payer and the providers. Just for a little bit of background on us, we are a management company. We've created over $125 million in shared savings just in the Medicare program alone. We started in Dallas. Our first contract year was 2014. One of our metrics of pride is that 81% of our network has stayed with us over 8 years. It's been very high performing. Typically, just so you have a reference for ACOs, there are about 500 in the country. Typically, we are in the top 20%, even the top 10%. Most of the years, we've been the top performing in Dallas-Fort Worth by savings numbers. And that's just through some really measured and disciplined work that we do to make sure that those patients connect to their providers and we get in front of costs instead of reacting to them. You're going to see a lot in this system of post-acute. It's too late. The costs have already arrived. We are all about getting people to be healthier before they're sick. So that's, I think, a big difference in what we do. So we have 2 Medicare shared savings ACOs in Dallas and 1 that is regional. These are programs administered by CMS, the Office of Innovation, which was created to solve those very problems that I talked to you about earlier today. So CMMI has dozens and dozens of models to innovate and test how they can create savings and improve outcomes to support what we call the triple aim. So one of these models is the Mssp Aco. It has actually been one of the more successful models for them. It originated in the Affordable Care Act, so it hasn't been around very long. The first ones were in 2011. So it's a young program, but still has had consistent and fantastic results. They've tested many forms of ACOs, including there's one that you may have heard of called the Next Gen ACO that just got retired this year, and it did not produce consistent savings for the government. But the reason I underlined the words accountable care organization is because really the definition is in that. We are responsible for the financial outcomes for Medicare patients that are assigned to us. We have to uphold all the CMS regulatory standards and industry practices in administering the program. There are a lot of rules. So we help providers who participate with us understand how to get access to an opportunity to earn in savings on their Medicare patients, and we have to pay back if we lose money on these patients. And there are ACOs who do go negative and they have to write a check to the government. Care, we are responsible for the health outcomes of the patients that are assigned to us. So whatever that total picture of care is, coordinating with the community, making sure the patients get seen, we get hit with that total cost of care and quality results. Organization, we must coordinate, communicate, and innovate together as a collective group. So CMS defines ACOs as groups of doctors, hospitals, and other providers who come together voluntarily to give coordinated, high-quality care to their Medicaid patients. So what we do is the ACO is a legal entity. The participants agree to create and join that legal entity and hold a contract with the government. And then we are measured on how patients are expected to cost versus what they actual cost. And that delta, that margin, is called the shared savings. CMS takes their piece and they say, thank you very much for saving money for the government. And then we get the rest of it and internally are left to determine how to pay out compensation within ourselves. The split between the physicians and the management is up to us, right, within that legal entity that we all share in. So one of the examples of there are a few of these in town. Baylor has an ACO. Southwestern Health Resources, which is a united effort between UT Southwestern and THR, was a next-gen ACO that just got flipped. In May, they canceled that program. So now they're opening a different form of ACO. You're going to be hearing in the industry, there's a lot of buzz around direct contracting entities. They're called DCEs. This is the newest ACO model created by CMMI, and it is much more like a payer model for straight Medicare in the rights and responsibilities of the contract holder, the provider network that contracts in it, and also their ability to offer certain things to their beneficiaries. So we're seeing sort of just more innovation, which is typical. Usually there's a new model tested every couple of years. Some of them go away, but MSSP has stuck consistently now and doesn't seem to be going anywhere. So I think everyone here will tell you all about the work that we do in this. And first, starting with Greg, I'll pass it off to him. But essentially, my point is this isn't going anywhere. We're going to see more versions of this, probably in the private payer environment as well. We have several contracts that resemble something like this from entities like Humana, Cigna. So whether your intent is to work in a government program or the private industry, this is something that you have to understand.
Thank you, Michelle, so much. I think this is, again, it's different, even though, as you said, some of the stuff we teach in the classes, it's different when you hear industry talking about what it is exactly that you do and what this means in the real world. So thank you. That's really super helpful for today. Thank you.
Isn't it always that you start talking when it's on mute?
Always. This is the world we live in.
Thank you, Michelle. My name is Greg Chesley. I'm the Vice President of Operations for Premier. In one of the things that I want to talk about in my background is I have been in healthcare for more than 20 years, so I won't say the exact number for you, but I have worked for HCA, Baylor, Tenet, and independent practices. So I have a broad spectrum of background and knowledge. I'm also an adjunct instructor for the Executive Master Program at University of Southern California. That being said, how about next slide? Awesome. One of the things that I want to thank Michelle for about going over the value-based care and how that works in our organizations and what we do for that. In operations, we try to operationalize or link those different departments that are in our organization, such as analysis, such as provider services, growth and development, strategy, quality, risk. And all of those different departments work interconnected to develop a focus on our quadruple aim. Our goal is to keep independent providers independent. That goal is kind of focused for us as we think that that can lead to the greatest cost impact in healthcare is by keeping those people independent. We think that the quadruple aim experience, one of the key points that we are focused on right now, obviously with the COVID outbreak, is care team well-being. Right now, we face a very large struggle operationally in all of our clinics for staffing, overworked, a lot of stress, a lot of people that are concerned for their health, and our teams go out there and work diligently with the providers to update them of regulatory changes or compliance changes. We had to help them shift gears to transition into telephonic medicine when we had the shutdowns with COVID. We have to notify them of any changes to billing and coding requirements that come about. Our departments also cover chart audits to ensure that quality and revalidate any data that they have on those patients. And Kathy will go over more in our clinical department programs, but our provider success team works with the clinical department to offer those quality programs to all of our providers to help reduce those costs. Everything that we do is to help the practice either reduce cost or help them increase revenue. And by doing those two things, we can help them continue to be independent. Some of our other resources that we offer are practice and provider educational resources. We have that access to value-based care contracting that Michelle had referred to with some of our vendors, Humana, Cigna, Aetna. We have a Blue Cross Blue Shield commercial contract. All of those can allow the providers to be part of a value-based system and earn additional monies based upon the quality and outcomes that they provide. We do have some access to some discounted vendor resources that we offer for the groups. And of course, we have much more. One of the things that our team focuses on is engaging the providers. As I can talk to right now about Q4, our engagement is to focus on annual wellness visits and having those patients that Medicare deems as assignable placed onto our patient panels. Those annual wellness visits, AWVs, and assignable patients being seen by primary care doctors reduce costs. If a patient goes in to see a doctor on a regular scheduled basis, then they're less likely to use ER services. They're less likely to need additional services outside of the hospital system. And we can talk to them about social determinants also. So we do focus on that aspect of the quadruple aim in everything that we do. Patient experience, population health, cost, and the well-being of their own care team. One of the things that I want to say is one of the reasons I got into healthcare, I looked at different opportunities when I had graduated. I looked at accounting over at a radio company. It didn't really appeal to me. What drove me into healthcare and what's driven me into value-based care is the need to help people. Because everything that we do and everything that I do when I was a staff accountant to the time that I became vice president of operations, I believe we focus on helping others. And by doing that, we give back to not only ourselves, but our community. And that's what Premier does. We give back to our community. Kathy is going to talk next about some great opportunities and interesting facts about our clinical programs and quality programs. So Kathy?
Actually, I think it's Mariana up next, isn't it? Let's see. Nope. Oh, it is me. Okay, great. Awesome. My name's Kathy Johnson. I'm a nurse. I'm a registered nurse, and I've been one actually since 1986. I started as an Army nurse and had some great times and great experiences. I've been a school nurse. I've been a case manager. I've had legal nurse consulting. So I've been able to try lots of different aspects, but bar none, value-based care is my favorite. Think about this as a nurse or any consumer. When the quality is better, it's less expensive. That's just so exciting to me, you know, to actually be caring about patients, not just because, and that it actually feeds, that it saves money. So it's really exciting to me. Okay. So for me, my department in there, it looks at 3 different areas: care coordination, quality, and cost containment. And I'm going to go into each of the 3 areas, but you can see how interrelated they are. If you're taking good care of a patient who had recently been discharged from a hospital, you make sure they get all the equipment they need at home and any resources that they may need. Well, the chances of them being readmitted or needing additional care definitely decreases. Getting those screenings and quality items and improving their outcomes is definitely going to make them not require as much utilization for emergency room or any of those kinds of things. So while there are 3 different areas and have different functions, they are definitely intertwined. First piece up is the quality activities. And there are many things that we do. If we start by abstracting data from the patient's charts, we're looking at specific measures that CMS has determined, hey, these are the things that if we do this for patients, they're going to have better outcomes. And so we look through the charts and we actually find the data that supports this. What we're trying to get to is less of that manual abstraction and depending on documentation like that, and doing it more automated. Having those blood pressure readings feed directly to the payers is where the future is going on this, and I'm very much looking forward to it. The next one is driving that performance. And how can we do that? We do that by outreach, knowing where we need to focus our efforts. Tracking that quality is the next one. So we're very careful knowing every single person that's supposed to be in a particular measure and whether they've met that or if it's still pending. We look back, had they missed this one 2 years in a row or 3 years in a row? And we really try and address those barriers. We have to submit that data. Sometimes it's to the payer and sometimes it's to CMS. This is actually the internship that I think Annie will be talking about. It's very complicated. Every payer can have a little bit different requirement on these quality items. So what's good for one may not be just right. So being very detail oriented, persistent, digging through different areas in the medical record really is important. We audit those abstractions. Are we missing anything? Are we including something that actually was not within the measure requirements? It's really important. I don't look good in orange, so we want to make sure it's right. And then that last one, I wanted to show that there's a lot of other pieces that fit under that quality umbrella. CAPS is a patient experience, and there is PI, which is promoting interoperability, which is kind of going back to that first part I said, where we really want to get that data speaking for itself. And improvement activities. So there's lots of acronyms and lots of other pieces that actually do fit into quality. The next area is care coordination activities. And you can see it could be specific things. And I should probably take a step back. Care coordination is outreaching patients. It's typically done telephonically, and you outreach these patients and there are things that you systematically go through. How do they need any education on their specific disease? Are they having trouble with certain symptoms or medications? Are they having any barriers to getting those medications or getting in to see those providers? Reminding them about all the health-based items and troubleshooting any of those problem-focused areas. Getting those appointments scheduled, this is not always easy. It could include things like home health or palliative care. It could include getting hospice set up. There are lots of different things that they can do to get the patient to the best outcomes for them. Finding those community resources, the transportation that's available, the meals that can be brought to their home really makes a difference for these patients. I also mentioned the transition of care activities. So someone is being discharged from the hospital. We noticed last year with COVID, many of the patients were really sick. These are patients that typically would have gone to a skilled nursing facility following hospital discharge. However, everybody was scared to go to a SNF with COVID, so they would go home. And we noticed a great deal of readmissions because very sick patients went directly home and didn't always have the support and care that they needed in their home. So these transitional activities can be super, super important. Another area that I am personally very excited about is remote patient monitoring. And what does this do? You may have heard about the Internet of Things. So there's equipment that the patients can have at home. It can be real time or it can be just episodic monitoring. And this data gets fed directly to the provider, to their chart with the provider. So they can have their blood pressure checked every day. They could have their blood sugar checked. They can have their oxygen levels checked. And think about, having this visibility and the ability to control and impact these patients while they're being monitored at home. It's really exciting, and I think it's going to get much, much bigger. And then we have the cost containment areas. So things like which specialists should these primary care providers send their patients to? We're able to find out, get that information together to say, okay, these are the folks that have the best quality outcomes. They, compared to their peers, they may not order extra unnecessary screenings or testing. For pharmacy, there is a huge difference between the cost of generic and some of the other brand name drugs, and just suggesting those alternatives and identifying some of those can be huge cost savers. And this is where it goes back to how everything's related. If there's one less barrier, the patient is able to get this medication, it's getting mailed to them, it's free, they're more likely to take this medication. So that medication adherence is going to go up. Their outcomes are going to be better because they're taking their medication every day like they should. So you can see how that feeds back into health outcomes and lower costs. Labs and testing, trying to get groups where we can maybe some economies of scale or different areas where we can try and save money as a group with those kinds of things. Facility utilization tracking. We look to see where are our patients going, and are they going to the ER there? Is it because that practice doesn't have extended hours? Is it because, or is that facility in particular much more expensive than the one down the street? We try and track that stuff and make it visible so people can understand, what some minor choices could make big differences. That post-acute care, like Michelle said, we want to avoid that. We want to keep patients healthy so they don't need this. But there are some big choices on that post-acute care. And if you have a network that you're using that you have an arrangement with, because they're high quality and they're thinking about the same things you are, keeping these patients healthy, it's going to be best for everybody. ER diversion there's a lot of really interesting data about that. What day of the week are these patients going in? What are their diagnoses? There are just so many different things that we can look into, and so many, just educating patients about some alternatives. Did you know if you went to the urgent care, there are so many even telephonic urgent care facilities now that it's 3 a.m. and you're concerned you have a urinary tract infection. Well, who wants to go to the ER? You could literally dial a 1-800 number and get your medication ordered at that time. So this is why I get so excited, because this isn't just better care for patients. It's like win, 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 win. Everybody gets excited. So I think that's it for me.
Okay, hi guys. I'm Mariana Garay. I'm a project manager here at Premier under the Strategic Programs Department. I help with payer operations and data analysis and just operations in general. I did graduate from UTD, so I completed my bachelor's in biology and then business administration, and then I fast-tracked into the master's healthcare leadership and management program, graduating in 2018. So like maybe some of you, I was originally interested in the clinical path. So I started out as pre-med, but in college I was involved in a lot of different organizations like HMA, ACHE, did a lot of community service. But it was until I really tried to get more into the workforce. I started scribing, that I realized I really didn't know that much about the healthcare system. And so I decided to learn more, and I took some classes and ended up landing an internship at Baylor's Fountain White Quality Alliance, where I learned about ACOs. And I was immediately drawn to them because they are just challenging so many of the problems that we've talked about today that still currently exist in the healthcare system. So my topic is going to be careers in value-based care. So you can go into the next slide. Okay, so I wanted to highlight some of the areas that are rapidly growing because of the changes in healthcare reform, the different payment models, care delivery systems. It's really brought about more complex organizations such as ours. I always have a pretty hard time explaining what I do. So, I don't think even my own family really knows like what my organization does, but I usually just say, I'm a project manager in healthcare on the administrative side, and that's about it. But if you really do take the time to learn more, I'm happy to answer questions and talk to you guys if you want to reach out to me after the meeting. So some of the rapidly growing areas here include population management, innovation, clinical integration is a huge one, patient experience, clinical informatics. You'll have heard about, big data, and there's definitely a very huge need in healthcare organizations right now to be able to track our analytics. Information security, that's become a bigger concern. Lean management. I know UTD has a really, really great green belt program. I completed that, and so I think that has been really helpful in how I manage some of my projects. So ask me about that if you're interested. We can go to the next slide. I did want to point out though that on this slide, I kind of listed out not our personal organization chart, but just some of the roles that you can expect in organizations like an ACO. There's just so much. that is a lot more specialized now. So I didn't include things like marketing or finance, or although those are definitely relevant in the healthcare space. I included more things that are something you may not necessarily think about as much. So I wanted to just go through some of these. Like, for example, if you have a more analytical brain, you like to work independently, maybe consider a career in analytics. Whereas if you like to be around people, you know, you want to be moving during the day, maybe something like a provider success manager or a provider success executive that goes out to practices to meet with providers, explain their performance, would be something that you could do. There's also areas like policy and contracts. We have you know, a whole section dedicated to just people that are trying to interpret the new rules and regulations and policies that come out, because it is so rapidly changing. So that might be an area to look into. I also linked the NACOs job descriptions in here. There's a link there. That's the National Association of ACOs. Because I think they do a really, really great job of outlining the qualifications, the skills, degrees, tools for some of these specific roles. So I would encourage you to read through those, you know, kind of assess what your skill levels are, and, you know, supplement for that through your education, or you know, through internships. I know Annie's going to talk about some exciting opportunities on the next couple slides. I did want to say that if you are looking to go into more of a leadership role, some of the most sought after leadership qualifications don't necessarily come from, you know, studying something or a certain degree, but it's more about, you know, how do you relate to people? What's your emotional intelligence, change management, your strategic thinking? How do you collaborate with other people? So any experience that can help get you those skills will help get you to where you want to be faster. So we can go on to the next slide. And then lastly, I wanted to end with just this slide. I know a lot of us have, you know, have been motivated to join a career in healthcare because, you know, maybe we connected to one of the problems you see here. Many of us may know someone that, you know, was severely impacted by medical bills, or maybe, you know, someone that had a preventable medical error. And there's a lot of distrust in the system. So I would start with finding one that you connect to, and then building from there, because I know that's what I did, and that's what brought me to accountable care organizations. And with that, I'll hand it to Annie, that is going to share some important and exciting opportunities.
Okay, can you guys still see that? Here we are. Okay. Having some technical issues. Can you hear me now?
Yes.
You can hear me. Okay. My mouse wasn't working for a second. Okay. I'm Annie. I know that I think some of you I might have been in classes with even last year. Just to give you a little background, I have my bachelor's in business from UT Austin, and then I went on to work in consulting for several years, working in various industries. And then I took some time off, took quite a bit of time off to raise my kids, and then decided a few years ago it was time to recreate myself professionally. And I entered the UTD Healthcare Leadership and Management Program a few years ago, and here I am. So that's really my journey to Premier. And I want to share with you, I know we're getting close to the hour. I hope we'll still have a couple minutes for questions, but I wanted to highlight these two exciting internship opportunities for you guys. The first one, the ACO Quality Reporting Intern, that is the one that Kathy had referred to a little bit. That falls within her department. It's very interesting, very exciting, but basically, just here's a few things you'll be working on. You're going to help complete those CMS ACO quality requirements, gain a deeper knowledge of those MSSP quality metrics that I know that Michelle had mentioned, and what's really exciting is you get to work in several EMRs. I know UTD, there's a class on Epic and some of the larger EMRs. Well, this is an opportunity to work in a lot of other ones, smaller ones that a lot of the practices use. You have, it's great because you can earn course credit. And I know you could talk to Quincy about how that all works, but you can earn course credit because you it's enough hours within the semester. Basically, it's 24 hours per week, but we're very flexible on scheduling, on which days and times you schedule that. And it will run from January 11th until March 31st, but we're taking applications now. And sorry for my dog barking in the background, but applications it's open and you can apply on Handshake. Oh my gosh, my dog, of course, decides right now to start barking. And then the other one is actually an immediate opportunity, the Provider Success Intern. We're looking for someone to start this semester even. This intern will support our provider success team, more specifically our provider business executives who work directly with the physicians and the practices. This is the team that really has that relationship with the practices. The work is mainly administrative and organizational assistance as the team assists the practices complete their required security risk analysis documentation. It's a great chance to gain exposure to a lot of areas within value-based care, such as the quality metrics, protected health information, promoting interoperability. It's just a great way to learn all of those different areas. And you will be able to establish contact with providers to go to reach out to them for required signatures on the documentation. And again, this is starting immediately. It's we're looking for someone who can work 20 hours per week. And again, you can apply on Handshake or you can send an email. I know Quincy sent out the job description with an email address you could send to as well. And with that, oh, here's my contact info. As the intern coordinator, you can always feel free to reach out to me with questions about the internship, or if you have questions for anybody else that spoke today, you can again reach out to me and I can connect you. And that is it. And now my here we go. I'm trying to get back to unshare. Something is going on with my computer, but that is it. And here we are.
Perfect. Thank you so much. Wow. Students on the call, do you have any questions? I feel like it was so thorough. I don't really have anything specific. There's a question in the chat that just has your email. Can I put that in here?
Sure. I can type it in.
Okay, perfect. And so you had said that there's the one internship that is available kind of right away, and then another that will be for the spring. What if students are interested, maybe they're getting close to graduation? What are some things they can do now? Can they keep a look for your opportunities on your website? Or what do you suggest if they're kind of thinking career opportunities? And there is a question, sorry.
Well, and just to answer that question, I know even if you follow us on LinkedIn, I know and connect with me, I can always let you know when positions are available. I know there's already some positions available, just to start looking into it and just making contact with us.
Perfect.
And
sorry, go ahead.
As well, I don't know what the percentage is now, but we've hired a significant portion of our interns. So that's one of the best ways to get acquainted with the team and the fit and the skill fit, right, is to intern. So we even have hired people after they left, just when the timing wasn't right. But when we get those applicants, of course, they come to the top.
That is fantastic. And what we often try to encourage students to do is like take a job description or a job that they've heard about and would maybe love to learn more about, and then kind of work backwards to say, okay, are there classes I should take, experiences that I need, something to make myself qualified as a candidate for that job? So I would just say for students on the call, just to kind of think about that as you've heard the different speakers today, and if something really caught your interest, and Mariana, you talked a little bit about this. So kind of think about how can you make yourself eligible for that now making connections, networking, maybe becoming an intern. There's just some great opportunities to make yourself a qualified candidate for when you're at that point. So well, that's really great. Okay, so we have a hand up here. Samal, do you want to unmute yourself or ask a question?
Oh, you're still on mute.
I'm so sorry.
Hi,
all of us.
Hi, my name is Simul. I just wanted to say thank you, first of all, for the presentation. It really helped in a better understanding of ACOs. My question was, for these internships, what are, and like for future job, like in applications, I guess, for Premier, what are you guys looking for in terms of experience? Because I'm similar to Miss Mariana, where my undergrad was a pre-med initially, and I decided I wanted to know more about the business aspect of healthcare. So now I'm pursuing my master's, and this is my first semester here doing that. So
that's a great question. Kathy, did you want to take that one? Like what you're looking for in terms of interns?
Sure. Attention to detail, organization, conscientiousness, being thorough, ways that you can, there's something that we actually do look for that we don't ever put on a job description, and that's kind of professional maturity. For my particular internship, you will be going out to the practices. So we want to make sure that you're going, you're not going to be giggly and silly, which some young folks have trouble with. So it's certainly, we want folks with a sense of humor, but knowing about the timing and the professional, and just being that really particular, looking for every detail. It really is important stuff. If we get this wrong, we're in big trouble. So, and we can't be everywhere. So we try and do as much training and education as we can in the beginning, but there's going to be a certain point where then you're kind of given a little bit longer leash, and we really count on you to carry through for us.
thank you so much.
now I just did it. Third time's a charm. Okay, so Nina, you had a question? We can't hear you. It doesn't look like you're muted, but we can't hear you. No. I know she's in the building. I can see her background. Maybe you can stick it in the chat if we can't get it to work. In the meantime, anybody else too? So Kathy has it here in the chat. Spring internship will start interviewing next month. So get your resumes ready, submit that, take advantage now while it's still open. Okay, and Amy's got her email.
I will say that I know it's difficult for folks to necessarily have healthcare related experience. That's one of the things that we're really excited to be able to offer you. But community involvement, groups, activities, retail actually shows a lot of the same skills. So don't be concerned that you might not have that experience. We definitely know that that's hard to get as an undergrad and graduate student.
I think that's really encouraging, because those are the questions that I get a lot from students is, okay, it's like this catch-22. I need to get experience so I can get the job or position I want, but I can't get that until I have experience. So it's like, which comes first? So to have organizations such as Premier who are, kind of at the place where they can take on students and help be a part of your learning journey, your experience journey. So, taking advantage of all those learning opportunities. A theme that's come up kind of throughout this whole week is, these opportunities won't just come at you. You as a student have to seek them out and kind of be willing to work hard and put in the hours. And when you do, your hard work and your dedication is seen by employers. So if there are opportunities to stay on as an employee after your internship is done, great. But otherwise, you're learning, you're adding to your resume about all these different skill sets, hard skills, soft skills, being part of a team. Certainly learning the business knowledge of an internship like this is really, those keywords where you can talk about the lingo. That's what came up earlier in a session today, was learn that business acumen, read, get experience. So when you sit down for an interview or you're interacting with people who are in industry like this, you kind of know what's going on and you can have a conversation, even if it's not, can I get a job? But it's, oh, did you hear about this thing? Or I read this interesting article. What do you have to say? And you kind of start building that for yourself. So you can be a little more confident when you are going for jobs or interviews or that kind of thing. So I think all this information you brought up today is just so helpful. Okay, I'll read Nina's question is in the chat, but I'll read it. So first she says, thank you so much for the advice today and being present with us all. Would you say Premier leans more towards being a for-risk value organization? In terms of preventative care or measures, does the company have a large emphasis on turning the focus upward streams directed towards primary care providers? Kind of two-part question there.
That sounds like a great question for Michelle.
Sure, I'll chime in. So the payers have a lot of appetite to put the providers at risk, and the more risk you can take, the more reward you get access to. So if you're unwilling to take downside risk, you end up with sort of transactional rewards at best. And usually you're forced, if you're on a contract of any size, any volume of members, to move towards sharing in that risk, because studies have actually shown consistently that providers at downside risk perform better, right? They watch the numbers closer, they have more skin in the game, so they care. So then payers are really, and think about it, you're a health plan and you've basically decided, okay, that's covered. I don't have to watch that anymore. It takes a lot of the pressure and the overhead off of you. So we are forced to navigate that. The providers are forced to navigate that. They actually, in some ways, take on some of this themselves. Medicare is reducing your fee-for-service rate if you are a provider who cannot achieve certain quality metrics. So one of the incentives of independent providers to join us is that that's really hard for them to do consistently and well by themselves. So that's what Kathy is referring to in the promoting interoperability, these MIPS requirement. That is as a result of MACRA, as you may be familiar with, which is, it affects everyone. If you take Medicare and you don't want to have a rate reduction, you have to care about outcomes at least a little bit, because you're going to get, so our providers actually got a boost in their fee for service because of the quality of work we did for them. They actually get an extra fee for service payment too. So like I said, we can't avoid, value-based care is a solution to a problem that we all live with as taxpayers in this country. So we have to be in the healthcare system ready to be at risk. So if you want to work for a hospital system, get ready to get dinged on something. If you want to work for a payer, get ready to get dinged, it's coming. There's some sort of, and all payment models are built off of government programs. So even if you don't want to work in Medicare, guess what commercial is using now? Most of the same methodologies. So we actually have a commercial, non-senior population product that we manage that is loosely called an ACO. So this is the industry now. In terms of preventive care measures, does the company have a large emphasis on turning the focus upstream towards primary care? And I want to make sure I'm addressing this correctly. Meaning, you can nod, Nina. I know you're not. You can thumbs up, thumbs down. But you're defining upstream as just further up the getting them connected, like we were talking about more early on. So annual wellness visits are huge. We've actually correlated between $1,500 and $2,500 yearly in savings from the annual wellness visit. And when we try to pin it down, it's just that the visit is proactive. It's not consistent what happens in that visit. It's the fact that you came in and you weren't sick and we talked about a plan for your health, right? So it's kind of like any other type of care. Car maintenance I think is such a great example. When you take your car in and you get your oil changed on time and you get your tires checked, how often are you going to have a blowout? How often are you going to end up with a $1,500 surprise repair? It's going to emerge in those visits, going to be less expensive. We do exactly the same thing. We make sure the oil gets changed And if the car gets older, the oil's getting changed more often, okay? We're gonna have to get you in there and get you with a special, a trained provider who can address your needs. So that's exactly the solution, if you ask me, to what we're trying to solve here. I also liken it sort of to the cost of preventive care is kind of like if you've ever worked in a restaurant. Did you ever hear how much it costs to put Coke out through the tap versus it's ridiculously crazy cheap, right? It's like fractions of a penny. That's preventive care. Antibiotics, visits, just doing preventive care is affordable. Doing reactive care, surgeries, hospitalizations is expensive. So my philosophy and what I came up in my MPH program is, why are we not giving more, both in the system and as the payers, to prevent cost downstream? And so that's exactly the creative solutions that this industry needs, ways for us to afford to do that, ways for providers to get access to that, like RPM. Can I give people a device so they can be remotely monitored, but later they don't have a hospitalization?
I can't tell if Nina's typing, but
she's nodding. So
no, okay, she's nodding. Yeah.
I like Nina's nods.
This is like emotional intelligence at its best. I'm reading body language. Okay, follow-up question. What EMR systems would interns be able to work with?
Kathy, how many do we work with? Is it 50 something? It's crazy.
It's over 40. And in fact, we still have some practices that are paper practices. But I think about key phrases that if you put this on your resume from an internship, multiple EMRs, and you can list the one in NextGen and Athena, you can list those. Your resume is going to creep up to the top. And understanding HEDIS quality measures, putting in key terms like that is really going to be helpful in the long term.
Some of that practical advice that you're giving, that I think is what our students are really seeking. What can they do and build on their resumes, not only for the internship, but also as they are learning these skill sets to, as they are moving through the program. So I think that's very helpful. So we are over our time. There's one more question. So all this, it's kind of there's several parts to it, but we'll probably wrap up with this. So it's a student who is an international student. She's in our healthcare graduate program. And so she's wondering about being an F1 student, or with F1 visa, and is she eligible for the internship? And then also is it possible to do the internship from home?
I think it probably makes sense. You can email me and I can find out. I don't know the answers to all of that yet, but definitely encourage you to reach out to me and I'll find out for you. Unless, I don't know if anyone else on the call has an answer, but.
Yeah, I think that's a great idea, Andy, to have, but I just will say we have worked with people on visas. So it's not an exclusion, definitely. Just, I think it's a personal circumstance, it's situational. So let's get the specifics and go from there.
Yeah. For sure. I'll look for your email.
Perfect. All right. Well, thank you all so much. All of you with Premier, this has just been so insightful, and we appreciate you carving out time today and these opportunities for our students, both through internships, obviously through our alumni working there. This is great. So thank you to, Michelle, Greg, and Kathy, just for providing these opportunities. And for students, we keep saying it kind of all week, but connect with people on LinkedIn, especially those who are alumni of the program. So Mariana and Annie, just who have been in your shoes and who have, are now just successful working professionals in the field. So, utilizing these connections and resources really would be, would highly recommend that. But all right, everybody, thank you so much. We really appreciate it.
Thank you.
Okay.
Thank you. Have a good
night.
evening.
Yes, take care. All right, thanks. Bye-bye.